Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and this episode was recorded with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
Admiral Choice of War, this song, the floor is yours.
Bei former sexes is fine. It's good.
Good afternoon. My name is Ben Ingram. Victor and I will be giving this talk together. Over the past couple of years, we've become good friends, partners, allies. Big point, this concept is not for us. It's not unique to us. A lot of other people, other than Victor and I, played a role in making this happen. A disclaimer, typical disclaimer, these speeches are hired for a public presentation. We're going to talk about the strategic operational backgrounds. We're going to review the PET, which Victor and I presented on last year, which that training is ongoing. And we're going to examine this concept we're calling Pickles, the long CLS, QCLS, spells Pickles. The name was so bad, you thought that might actually stick. So this is a known no. We know the golden hour was good. Really did well. And then we realized the future of the golden hour may not be a thing. It may be a golden day. And then you see things like the golden hour is dead, return to guerrilla warfare. But here's the fact you can't get about. The golden hour is dead. The need to save lives has unchanged. That is still a fact. So this is article, the UK Surgeon General, who I greatly respect, was on this article. And he basically did not like the term the golden day. He said we extend our timelines to 24 hours. Thinking the golden day will magically save lives because people will basically die. We need to stop using the term. It's dangerous. In this other piece out of the UK, and I reference the UK many times because they're actually really, really smart people. Pretty much all thoughts of Afghan death. But they were looking at this problem set of if the injuries in a future large-scale combat operation are exceeding our medical capabilities, option one is do nothing and accept it. That's an option. Option two is to rapidly scale your medical care needs, which if you look at the training timelines for nurses and doctors and medics is out on the table. And option three is to shrink the requirement for medical capabilities and expectations, which will be very difficult. This is open source information. And we heard some talk earlier today during the opening talks about how we were protecting World War III. These are the attacks by Russia on Ukrainian healthcare facilities. There have been over 1,800 since this war began. I recently pulled this out. If you look at the plot, they had an initial burst of it. But these are all over at night. I refuse to believe these were accidental attacks. And then we run into what I call the math problem. I'm going to give you 5 assumptions here for the sake of this math problem, and I'm going to say all 5 of these are likely false. But in order to talk about it, we'll assume they're true. We're going to say our medical capacity, military medical capacity is available and adequate before the war began. Well, it's notion to say false. Our civilian healthcare system is fully staffed, not competing with military medical personnel. Likely false. The medical attrition rate, meaning the death from enemy attacks during the course of the year, will never be more than 5%. Nevertheless, medical education institutions can quickly scale training capacity and mass attrition. And all attrition will be on day one of the year when we can immediately end training a place of forces. This is what will happen to your medical force with those 5 assumptions during the course of the war. Assuming a physician takes 7 years, which is on the low end, surgeon, neurosurgeon takes longer. By year 7, you're going to have a significant drop. This is stabilized because your replacement forces begin to come online, but you will never recover during the course of the war. The same thing for the nurses. If we change this to infantry time, at 50% loss, you definitely buy 35% loss. The effectiveness of the infantry battalion is culminated, it can no longer do the job. So we have a large risk if we don't find a way to increase their capacity, if we're pushing our doctors and nurses forward, we're not protecting that capability for capability. If we contrast that with this concept of a combat medical technician, not currently a native word, needs to be, a person who is to train for 6 months with specific skills, while all lives have equal value, that skill set can be retrained within 6 months. It will never fall close. If we look at why we need to push skills forward, this is open source for the BBC. The Russians is saying at that time they only admitted to 70,000 deaths and said that 39% of those were federal. If you do a little math, that was 27,000 preventable deaths. That is almost 3 divisions of people that are dead that even the Russians in open source said did not need to be dead. This article posted in Joint Course Quarterly about 2 weeks ago. Admitted I'm the second author, George Barby's the first. This honestly was George Barby's brilliance. I'm not hard on thinking this. But it started with discussions we had 2 years ago that if we say that the medical community is just have to take it, there's nothing we can do, there's going to be deaths and they're going to have to happen, we reject that assumption. We believe that we should make all efforts to regain both that shape. Again, if this is infantry and we told an infantry battalion commander that they're going to take it and they're going to lose and there's nothing they can do about it, so just sit back and take it, they would never accept that. They may say, I may die today, but you're going to bleed. And so we identified these 3 offsets, far forward interventions, technology and innovation to make it available for us more effective, and finally using ALS partners to increase our collective capacity. And looking at the far forward intervention, under Victor's leadership in the past year, they developed a prolonged evacuation transport concept to deliver to Ukraine, our forces SOF. The reason this was originally developed was a lack of interoperability for training their various nations. So that when people were trained by various nations in various ways of what they call medic, which is different by 33 nations, but they came back, they're not interoperable. So we developed a standardized training package delivered over a 3-week period. The reason we gave it the Unit A was in the training practice did not align with any off-the-shelf U.S. JTS products. CLS was not enough. CMC assumes you already have an extensive medical background. BCC was way too extensive. The issue we had with BCC at the time was not that it was extensive, but it also was not an algorithm to be easily taught. There are many branch-lines and system trees that the advanced infantry person actually uses. If you're not advanced trained, you wouldn't necessarily pick up on that graph. So what we found, do we have trauma registry evidence that this is effective? No. What we do have is evidence that the buyer of the product, so if we put market pressure as an analogy, the buyer of the product asks to repeat iterations of the course, so we get to at least say they find it useful. What we found was paramedics, felchers, which is, say, a Russian version of the paramedic that's still floating around, and physicians could engage the course. There's enough of a medical background. If they have a medic trained between 1 and 3 weeks, they could not engage the course. But because we're using SOMSA, which is a NATO Special Operations Combat Embedding, which has been trained for a minimum of 20 weeks as instructors, we could safely say they probably could engage the course because they're teaching as instructors. So the key lesson identified, 3 weeks is too low. 20 weeks at SOMSA, which is an aggressive training program, is probably adequate. What remains unknown to me, it's uncertain to me, is whether a 16-week AIT sulfur, if we use the US 16 whiskey as an example, are they adequately trained at baseline to fully engage and succeed with that program. So this brought us to the gap that you still had, that gap that had failed to resolve. What we found is the people that had the patient the longest in this chain of evacuation, they were the CLS trained people. And CLS would typically be done within, we'll say, 30 minutes. But if they were looking to hold on to that person, there's the tactical realities for 20 hours. We had a person whose skill set was done within 30 minutes if he still had plus hours to hang on to the person. So in further discussion, we realized what we needed was a bolt-on training package. A long training package to get bolted on to select CLS trained persons. When we realized that was BCLS, that spelled Pickles, thus the name Pickles. If we look at this from the NATO doctrinal standpoint, NATO timelines for the conventional force are 10, 1, 2 plus, meaning care within 10 minutes, Rule 1 care within an hour, but Rule 2 care surgery within 2 hours. The data soft diagonal timelines are 0, 30, 60. What was practically happening was it was all service members would happen at the point of injury, followed by CLS, followed by a giant gap. So out of this, under Victor's leadership, the PET program was developed, which basically is assuming the role of the combat medic foreman and the provider paramedic during that period of transportation from the casualty collection point back to the first stabilization line. That still left this giant gap between all service members, CLS. And our proposal is that there's a missing training bolt-on that we're calling Pickles for the time being, which would be a task shift. This is somewhat, probably going to be controversial, but we task shift skills traditionally given to medical personnel to combatants with increased medical training. Now, this concept isn't new. AT Delta isn't a bat. But we're now saying that this is going to have to be where the task shift happens. Now, is this completely new? The answer is no. I'll give you an analogy. This wheel on the right is something that they use to harass West Point freshmen. They give them a round cake at the table. The freshmen are tasked to cut the cake into equal pieces for every person at the table. 2 people, 4 people, 8 people. That's easy. But when you get 5, 7, 9, that becomes a much more difficult task to ensure it's a big cut. So that's historic that we'd have these cake cutting templates where they would cut on the 7s. Every 7 make a cut, and that divides it. And the point I'm making is the human body is 100% interoperable. That has not changed. Human physiology has not changed. And I personally believe that the total number of actions that have to happen from the point of injury to arrival at the first surgical capability, the first NTF, that has not changed. What is changing with Pickles is how we're cutting that cake. We're saying the certain tasks that would have happened later need to push forward, and the tasks and the authority to do those tasks is the pathing pushing the table further into the timeline like they did in the GWAT era. Now, am I brilliant? Nope. The Brits thought about this several years ago. This is an article that was written by a couple of British officers. They used it among HIPAA, and they've identified almost identically the same things that Victor and I have identified that we need for trust. So this happened simultaneous in the literature review. We identified these topics, which takes the Victor and the Buckley.
This will be about evolution. So, how we came from the pet concept in Pickles, and I'll try to explain some of things much. To this, I need to come back a little bit to the history of pet. So, just show here reminding some high values of that. It was created in February 2023 after we had some meeting together with Ingram and Ukraine South. We identified some gaps that were enlisted by our Ukrainian colleagues, and no existing pipeline did fill those needs that were asked by Ukrainian South. In fact, 2 months later, we created our baby, which we call PET. This is advanced name for that. And we didn't expect us, year and a half later, we'll come to the point that we need to find some other solutions. So still we have one more unwheeled kit that we named Pickles. So why is it so? The program involved a lot of experts from almost 10 different countries. We run it mostly in New Jersey. But the concept for the pet training program is to answer the questions using our expertise, those that are raised by our Ukrainian partners. So, in fact, it's a kind of ongoing program because we have to reflect all the current needs and all this what is changing in the bubble space. So, the first part of request was to train the medical evacuation case. But in the first stage of training, so 2023, it was mostly the training for the qualified medical personnel. So we are talking about physicians, nurses, and paramedics. This was started to happen. We realized that cadre of the qualified medical personnel, is disappeared. They have no more to provide and to fill this training. So we had to adopt a very advanced training program addressed to max. And you see very well on this picture how long does it take to train this personnel. And we had to convert it for the combat medics having about 3-4 weeks Q course. So that's the all base they have. As far as now, we trained over nearly 150 personnel, and this is an ongoing program as I described, so we expect about 80 more by this year. However, still with this need just to adapt to very different personnel. Just to highlight several certain products that are the base of old concept is the evacuation time. We are speaking mostly about timing, and this slide presents you something that is totally out of our standards when we are talking about reaching the first medical point within 12 hours. What is new as well? Probably the injury pattern is another issue that differs this experience from our previous ones. So mostly we deal with all the different kinds of the blast interpretation wounds with a very small portion of gunshot injuries. But we also need to ask one question, that this conflict also has a kind of a strong overrepresentation of head, neck, face injuries. So this is another point. And the relatively lower number of a possibly tourniquet intervention injuries like young injuries. We came to there are very few studies regarding the postmortem part of this. So it's very much like, other conflicts, mainly except of one thing, quite high percentage of burns that cause the death. It's almost 10%. Created mostly by the TOS systems of the German variable. And we also find a very specific thing that is a preventable death, as you see, mostly related with two main factors, is breathing, so mostly this kind of bit that we can control, and tension pneumothorax. But we also identified one more thing that maybe is not something that can be a reason for preventable death, but for sure for unnecessary legs loss. So it's timing for the tourniquets. All of them mostly go out of the standards. And you see the result. So those athletes that had about 12 or more hours tourniquet or place, and when you look at the injuries, probably most of them could be at least converted or changed to any kind of dressing that would be sufficient, not they were finished anyway with unnecessary application. So we tried to figure out where can we make some kind of improvement. Probably when we are talking about the preventable death reduction, we can do almost nothing. 12 hours is 12 hours. We cannot change the time. But maybe we can do something more about the people who are dying of wounds. So by implementing more and more into the field, probably we can do something about this rate. For sure, when we are talking about another factors like complication rate and preventing unnecessary amputation, those rates of success are potentially much better. And of course, increasing the patient comfort. So coming back to the timelines that were presented by Ben, the PET was initially designed to treat the patient from something they call ambulance exchange point to the stabilization point. But we still see two more opportunities for recruitment. Those are the office. So is the stabilization point where we see big changes once the surgical T is present there. So result there, O1 is just something that has the surgical with this. But the Pickles concept is coming here. So if we don't find solution before PET, probably the results will be known. We identified several lessons, and some of them where we can need for those opportunity for improvement. So we need to find something which would be kind of gap filler. This would we name Pickles. And what should we include? Where can we be better? Airway solutions. Those are the subjects that are raised by our Ukrainian sports. better understanding of methods of chest trauma interventions, tourniquet coverage, TXA application. What is the route? Maybe we'll be able to change it into intramuscular or oral. That works and possibilities for that. Otherwise, patients receive TXA after 8, 10, 12 hours. It is done. There. You don't know what is the real medical on top of that. What are the best blood protocols? Ukraine is a huge experience for dry plasma. Just to give that example, the walking plant bag in our study doesn't work in the front line. Prolonged management, baby grotable. One of the most important things because they remove morphine by different reasons, but they still stay with pit packs. But metamizole is enough effective for 12 hours or longer. And of course, how to solve and how to treat, to train the monitoring system. This is one of the examples of the slides that created ovarian drainage codes makes things simple. So just coming to the annual audits that are pretty different than those that we are used to. But to come to the trauma core site, we're asking training people who don't have medical background. Probably solutions like this are something that can work. So that we are coming to a kind of final point. What should be contained by it? What is covered by Pickles? So let's focus just on Pickles. So it's a massive bleeding, but tourniquet coverage included in that. Better understanding of chest trauma, setting up the idealize. But how can you use it? What will be the optimal way? Hypothermia, pain management, trauma cocktail, patient monitoring, and possibly triage. I still keep it with a question because we are talking of the people who are medically trained, but they are no medics. As you see, the scope of those capabilities is really very, very big. But without doing that, probably we will not get to those improvements that we hope we still can find. Of course, we can talk about technology. So there are very different attempts according to resupply, according to the patient evacuation. Of course, you also have some solutions for the underground terrain solutions for the medical facilities. But still, this is a kind of concept. We are talking about a chronically contested area, so most of those solutions are not so easy to use as well. Even if you dig something underground, you will be probably discovered. And you also have to consider how dynamic is the front line there. We'll take the question if there are some at the end, so but I will kindly ask you to continue, okay?
But for those of us who are old enough to remember, there was a point where soldiers carried IV fluids. Around 50 years ago, those were pulled out, entire generation's gone. When Victor mentions the idea of having pre-derized plasma, I asked him a question, was the concept right if fluid raw? Some of the things we're talking about as we explore this Pickles concept simply don't exist. But I think we're not very far off from every soldier potentially carrying a plastic bag, their own pre-derized plasma. So questions of allocation, questions of who gets it, who doesn't, the answer is it's yours, it is yours. In terms of safety, we don't have to worry about you getting an infection yourself. And then looking at other options that are easier to take forward in the trench, such as oral TXA. Is available by prescription in the US, is actually over the counter in the UK, usually used for dysmenorrhea. It has onset about 2.5 hours. However, if you cannot give it IV within 3, you're not give it. So maybe with an 11-hour half-life, it gets the potential to buy time. And then some of the medications Victor mentioned, Acamazole or Penthrox. Penthrox is used in parts of Europe. It's available in Canada. It was an anesthesia med. It was removed from the market for some concerns about side effects in the U.S. However, I don't think it's been looked at in the U.S. It is inhaled. It's this guy with the little green pipe there. In Victor's experience at the Trauma Surgery colon between Acamazole and Penthrox, they're highly effective when used together. The other advantage of Acamazole is pretty much every route you could possibly need is available to include PO to PR. If a person does not have a mouth and does not have an anus, they have a lot of problems. So to put that forward in a PFAC or an IFAC, we have options available to give it to a battle buddy to leave. This idea of a crawl-on first aid kit is not new to me. Found an article where it has been looked at, and they did make the point that a clinical set of bags is not a clinical set of capabilities. And we need to keep it in mind. And for it, electronic signatures. So what will the future of the PFAC look like? The answer is, I don't know. The U.S. perspective, I think it'll need to get designed and standardized. But the key part of Pickles is we have to embed the training into people. The PFAB is not a solution to a training net. And at that point, the material itself could be on demand. There could be a point where one person on PFAC could be, well, PFACs, you bring the 4, but you can have to have the trained person. Victor mentioned airway solutions. I put a question mark of Reich. That is a intuitive conscious person, but training a non-medical provider, the medic always gives me pause. They tend to get overused. But if I look at some of the discussions we've had from our JMED past year, even with the chief scientist of NASA, NASA's working on ways to develop ultrasound capabilities for deep space, where a minimally trained person for a standardized protocol could reflect the ultrasound images to make decisions. Or are there ways we could find templates to make it right in something in versatile training to perform the technical part of it? That's a different issue from the judgment part to do it. Are there warming supplies when I consider people the feedback? And when we talk about wound care for long periods, oral antibiotics are an option. They do tend to cause later antibiotic resistance issues, which I've seen maybe an issue with Ukraine. But there's old things that we could do. Dakin solution, which is basically an old school bleach. We're seeing possibly having a dry tablet that put into a canteen of water. A certain dose could create Dakin solutions for a forward topical dressing. And finally, the question, do we need to get the ability of the PFAT, to camouflage? Cover concealment, I think, is the capsule future of the medical that they did not address. That's not a new concept. Amateur kinds do it. I don't think the medical community has ever had to train or been told if you go to World 1, 2, 3, or 4, the commander is responsible for covering concealment, just as infantry commander would be expected to be responsible for that. So that concludes our concept of Pickles. We're still sorting through it. Victor has, with his own unit, done some early stuff. The more we dug into this is a way more complex problem than we thought. We initially thought we would take pet down at Pickles, done. And then we realized this is a wicked problem set. I think it needs solving. We're going to solve it within the training we're delivering. Probably be a beta version. But I think it requires larger attention. That concludes we'll stand by for any questions.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.